Hello, I'm Alan Weil, Editor-in-Chief of Health Affairs. Thank you for joining us for today's Policy Spotlight discussion. Policy Spotlight is a series of virtual events Health Affairs launched last year, featuring in-depth conversations with influential health policy experts. Previous Spotlight events featured CMS Administrator Chiquita Brooks-LaSure, CMS Innovation Center Director Liz Fowler, and most recently, FDA Commissioner Robert Califf, and many others. If you've missed any of these events, as they occurred, the conversations are recorded and you can view them on our website. Today, we're joined by Jonathan Blum, Principal Deputy Commissioner and Chief Operating Officer at the Centers for Medicare and Medicaid Services. As anyone in the health affairs audience knows, the programs administered by CMS touch the lives of more than 100 million Americans. Now, CMS has broad responsibility over longstanding programs like Medicare and Medicaid, but also implementing new initiatives, including, for example, provisions in the recently passed Inflation Reduction Act. The CMS strategic plan covers topics such as equity, expanding access, engaging with community partners. We'll discuss all of these topics in our conversation today. Before I introduce my guest, if you're watching us live, you can submit questions during the event using the Q&A box in Zoom. Short questions presented earlier on in the session are a little easier for me to get to, and if they're of general interest, I'm more likely to be able to weave them into our conversation. I'll do what I can. Now, it's really my pleasure to introduce Jonathan Blum, as I said, Principal Deputy Commissioner, Chief Operating Officer of the Centers for Medicare and Medicaid Services in the U.S. Department of Health and Human Services. In this dual role, he oversees CMS's program policy planning and implementation and day-to-day operations of the agency. Mr. Blum has more than 25 years of public and private sector experience. He was Executive Vice President for Medical Affairs at Care First Blue Cross Blue Shield, professional staff member in the Senate Finance Committee, a program analyst at the Office of Management and Budget, and has worked in strategy and management consultant. This is his second stint at CMS. Previously, he was Deputy Administrator and Director of the Center for Medicare. So Mr. Blum brings terrific experience and knowledge. It's a great pleasure to have you with me today in the conversation. Thanks for being here, Jonathan.
Well, thank you for the opportunity, Alan. It's great to see you and really happy to be here today.
Thank you. It's great that you're spending a little time with us. So I always like to ask at the beginning of a policy spotlight about priorities. I ticked off very quickly a few elements of the CMS strategic plan. It covers a lot of ground. You have an incredibly broad portfolio. If you could just start maybe by telling us a little bit about what you see as your priorities in your role.
Thank you for the opportunity. CMS last year set out a course to define 6 pillars that will guide CMS work going forward. And these are pillars that really feed to all of our programs, be it Medicare, be it Medicaid, be it Marketplace. And the first is that we want to address healthcare equity and to ensure that all of our programs are doing everything we can to ensure that our programs work better for all people throughout the country. Second, we want to expand coverage, be it Medicare, be it Medicaid, be it Marketplace, but to ensure that we are working towards more people being covered by CMS programs. Third is we want to engage stakeholders differently and to really challenge ourselves, our teams, to talk to stakeholders, particularly those that have lived experiences with our programs, to ensure that we can make policy better, make it more responsive, and to flip the conversation from CMS proposes policy, gets comments, possibly make some changes, to really engaging stakeholders early so we can make the best judgments, make the best policies going forward that reflect that on-the-ground experience. Fourth is we want to promote innovation. And so we are tremendously excited by technologies, new care delivery models that can make healthcare better, make it safer, make it have better outcomes, but also lower total cost of care. Fifth is that we are very mindful that we are stewards to a large share of total healthcare dollars, and to spend those dollars as wisely as possible. And last, to ensure that CMS has best-in-class operations, that we are setting the pace for how we want the healthcare system to run. That means to keep our own house in order well, but also to take that to promote how we think the healthcare system should be run, should be operated, should be delivered to those that need CMS programs the most.
It's a great roadmap, and we'll try to cover at least a few of those elements in our conversation. You have this very unique perspective. You were at a very senior level in the agency a decade ago, and now you're back. Of course, we've been hit by a pandemic, but a lot of other things have changed in that period as well. I wonder if you could offer some reflections on what's different now and what challenges you face today that either you didn't see a decade ago or that have changed in fundamental ways.
Let's say there's three ways, for me at least, this agency is much different than it was during my previous tour here. The first is the scope. CMS is much more deeply involved in many parts of the healthcare sector and growing to the social services sector than ever before. When I first came to Washington, D.C., close to 25 years ago, it was probably fair to say that the majority of time the agency spent was on running the traditional Medicare program. And so if you were to come to CMS, chances are you're thinking about payment policy, beneficiary policy for those who are part of the fee-for-service Medicare program. Today, Medicaid, now the largest population to our programs. We are much deeply focused on private healthcare insurance markets. We are much more deeply part of the quality fabric to the whole healthcare system, that our teams that lead survey quality standards, that's now the biggest part of CMS. And so we spend much more time thinking about the safety, those clinical standards to how the healthcare system should run. So first for me is size, scope to CMS programs. And while Medicare is still a large part of our work, much more time now is spent focusing Medicaid, private insurance, clinical standards, how we think about the infrastructure to the whole healthcare system. The second change is, particularly with the COVID pandemic, CMS is much more active in the overall public health response. We are active partners working with CDC, the FDA, really in kind of several key areas. CMS payment flexibilities that were triggered by both the Medicare program and state Medicaid programs during the COVID pandemic kept the healthcare system functional, helped to maintain care access. And so CMS is deeply involved in thinking through policy for how we pay for vaccines, therapeutics for COVID-19. And so we see ourselves, this has been a trend for some time, but the COVID pandemic really sped up this trend as being deeply ingrained, part and parcel to the overall public health response. And the third sort of takeaway for me is a trend that's been happening for quite some time, but really is beginning to challenge more how CMS thinks about its programs. And that is the rapid enrollment to managed care delivery. Medicare beneficiaries, those who are eligible for both Part A and Part B, have chosen to receive their benefits through a private health plan. Medicaid, as you know, probably better in the whole country, has been a tremendous shift towards managed care delivery. Private insurance that we focus on by definition is run through private health plans. And so as CMS thinks about how it can best influence better healthcare delivery, better healthcare outcomes, better coordination of healthcare and social services, we have to think about more how we work with influence steer managed care plans to embrace and to fully commit to those goals. So the notion that CMS, a direct payer, is become diminished, and CMS becoming a contractor purchaser for health plan services has become, in many respects, the dominant way that we work in the healthcare system.
Well, I guess that's the advantage of going away and coming back, is that things that were gradual, it's like your kids, they get older and you don't notice, but when you take them to someone who hasn't seen them in 5 years, they say, wow, you've grown up. So I want to focus a little bit on mostly the first and third of those elements, although they're all, of course, all three of them are important. It reminds me, when I took over the Medicaid agency in Colorado in the early 1990s, we were transitioning from a fully fee-for-service system to very rapid expansion, move into managed care, as many other states were in that time. And one of the things I noticed is that the skill set of my team, the staff, had to change dramatically. As you mentioned, you're moving from really claims processing, eligibility determination, rate setting to contract oversight. And that's a complicated thing. We, of course, in Medicaid, we had more, we have the ability to have mandatory enrollment. You have more, the Medicare statute provides people with more choice on the Medicare side, and that's a form of accountability. I wonder, as you're describing these changes, if you can say a little bit about how you think about the people you need to do these new functions that you just described.
Yeah. I mean, it's a great question. And it's, we think about the workforce needs of CMS for the future, not just today, but say 5-10 years out. The things that we think about fall into a couple of different categories. First critical need to us is we need more clinical knowledge coming into the agency, clinicians, physicians, nurses, and other healthcare providers that can really bring deeper clinical insights to how we think about CMS programs. It is no longer sufficient for us just to know kind of how the payment policies work. We have to be consciously focused on how the healthcare systems, the clinical workforce will respond to our payments, to our programs. And so whether it's considering coverage for breakthrough drugs and breakthrough technologies that are coming at us fast and furious, whether it's thinking about how we design the best care models going forward, how we push managed care plans to build networks that are more equitable, for example, that just needs much more clinical insights, clinical knowledge. And so I do expect that CMS will be expanding its clinical workforce defined broadly over the next 5 years. The second category that comes to mind is data scientists. And so we have done tremendous work that happened during my first tour at CMS to unlock CMS data to bring new insights to the healthcare system. But we want to be the best users to that data within CMS, so we can really understand our programs, our operations, and make good decisions going forward. That sixth theme that I talked about, the sixth pillar, best-in-class operations, what that means in part is we are capturing every data point that we can capture, particularly around beneficiary experience, and be able to understand, see it, capture it back to our policies going forward. And so second category for workforce development will be data science, those that can help us better use, combine data together and build processes, design processes for how we better capture information to make policy going forward. The third piece I would say is to your point about managed care contracting. The healthcare system gets more and more complex, and people that have firsthand experience, firsthand knowledge regarding how providers, health plans, the entire ecosystem works. That's a skill set that's going to be much more valuable to CMS going forward, given how reliant that we are on third-party actors, private sector partners to carry out CMS programs. For just about everything that we do, we rely on partners, providers, third-party entities to carry out the CMS mission. So those that understand how the system works, how it should work, and how you can really influence it to better serve Medicare, Medicaid marketplace, consumers, beneficiaries. That's going to be much more need going forward.
You've prompted a lot of questions in my mind. Let me try to get through a few of them. The first is when I think from the position of health affairs, we publish a lot of papers on Medicare, and often one of the limitations is that they're only using the fee-for-service data. So if we're reaching this 50% point in Medicare Advantage and we want to have a robust understanding, how do we open up that black box? Obviously, some people can get the proprietary data from the plans, but how do we really get to a place where we can fully understand and analyze both halves of the program on somewhat of an even platform? I've got more questions, but I'll start with that one.
Yes, so our teams are making much more available the plan encounter data, and so that's data that is better than it was, but it's not as complete and it's not as reliable as Medicare fee-for-service data. That's going to improve over time. But I think to your point, not just for kind of analyzing how the programs should work or could work, but that real-time surveillance that's critical to our best-in-class operations. Simply using fee-for-service Medicare data will no longer be sufficient to proxy or to analyze. Well, this 50% statistic is nationwide. In some parts of the country, it's 70-75%. And so in some parts of the country, the MA program, private plans, is really the dominant part, or that's how people experience generally the Medicare program. And so CMS will continue to make more plan data available to researchers, but I think the urgency is for us to better use that information, have it be more reliable over time, but studies that combine those two pieces together will be much more accurate and give us greater insight for how the program is working.
That's good to hear for a variety of reasons. I'm also thinking about the agenda for CMMI and all of the sort of micro, and by that I don't mean small, because some of them are quite large, but the individually targeted and tailored payment models and payment designs and payment approaches, which again overlay on top of a fee-for-service system, but don't really fit within the different structure and dynamics of an MA plan. So is there, how do we think about our ability, you I think very appropriately talked about sort of accountability and understanding what's going on, but how do we learn efficiently and accurately about the effects of these payment models as the pool of clinicians and patients in the fee-for-service side shrinks, and there isn't always alignment between what's happening on the traditional side and what's happening in the MA plans.
Yeah, it's a great question. One of the insights that Liz Fowler and her team have brought is that if we're going to be truly effective at building payment models, building delivery system transformation models that truly change healthcare for the better for Medicare beneficiaries, that we're going to have to build models, consider models that can be adopted, kind of easily deployed by managed care organizations. And this is tremendously difficult for a couple of reasons. One is different plans in the fee-for-service Medicare program have similar but different claim systems. But I think from a health plan perspective, I mean, it's part of their value proposition to the market to have care models, provider contracts that distinguish themselves from their competition. So many people suggest that, which I think is the right direction, that we really have payer alignment going forward. But the realities of the marketplace would say that a health plan is going to be less interested to partner with CMS, particularly when they're competing with another health plan, really on the kind of value proposition that they're creating for their network, but also for their beneficiaries. So we have to do better. And so one is we have to do better to align on quality metrics and get buy-in, get influence for a common set of quality metrics. Two is we have to really come to better alignment. What is the purpose to these models? And how can we convince more physicians to participate together? How can we create more value to beneficiaries so they seek providers who are participating in these models? And stepping back from the health plan participation, I think there's two fundamental challenges that we, CMS, and also payers together need to do better on. One is to convince physicians that these models better serve them, better serve their patients, more importantly. And so I think the way these models tend to be operationalized is they require more accurate coding for risk adjustment purposes. So the physician get asked to code a lot more than they currently code. They get asked to complete all the quality checks in order to clear the quality gates that CMS sets and can also private payers set. But to the physician experience, they're probably still experiencing fee-for-service Medicare, code more, check more boxes to ensure that quality measures can be maximized. I think we really have to think hard about how we together convince physicians who are skeptical that new care models better serve their patients. And then second, we, CMS, with payers collectively, need to do better to articulate what's the benefit to beneficiaries. And so that our research shows that when beneficiaries hear terms like accountable care, value-based care, new care models, they hear care being restricted, they hear care being withheld. Is the opposite of the goal. The goal are to bring better care, more insightful care, more care tailored to the patient. So in addition to better disseminating these models through broader ecosystems, we have to do better to convince physicians that care will be better, their time will be better used going forward. And then second and third is to better convince patients and their families and their caregivers that these models will better serve them going forward.
I have one more question in this area, and then we'll move into a different topic. But actually, I had this question before your last comments, and now I think it's elevated even more so by them. When you went over the strategic priorities, you talked about bringing in community voice and the voice of lived experience. And as is often the case, and I please don't take this as criticism, but as people like you and me sit and talk, the air becomes more and more rarefied. The acronyms start coming on thick. We're talking about very, you were just talking about coding and message, and when we were talking about the skill sets you need, you were talking about some technical skills that are hard to find and are not what the average person carries around with them. So how do you think about these two things? On the one hand, the need to interact with and oversee and regulate and pay appropriately to these very complex systems, and at the same time, the desire to bring in the consumer voice in a more robust way into a system that is very, very hard to understand.
Yeah, I think it's a great question. I think it's a tension that we face every day. I personally have been dedicating at least 1 week per month to traveling throughout the country, really organized by our 10 CMS regions. And we focus on purposely a different set of meetings than may come to CMS naturally. And so one of our colleagues really speaks about that our purpose going forward is to really listen to, seek out those who are underheard traditionally in CMS world. And so we've been purposely going out to convene stakeholders together in communities that generally are not those that are directly paid by the Medicare programs or by state Medicaid programs, to capture some of the insights that I think you're describing so well. And so we met with this week healthcare navigators who were talking about just the challenges of communicating what insurance terms are to people that never had healthcare insurance or that speak a different language. And so that brings to us insight that we need to really work hard to think about how to communicate better. So let's add to my list of skill sets for the future is people that really know how to communicate better to beneficiaries. We met with federally qualified health centers that were describing the tremendous challenges they have in getting access to children, to adults that need behavioral health, that need oral health. We've heard from, we toured large safety net hospitals that right now have ERs that are overflowing. And part of it is because they cannot place people into behavioral health settings right now. And so that third pillar that I described means to us, we need to actively to engage, to listen, to meet, and not just those who have strong voice here in Washington, D.C., but those who are serving front lines, working with patients, working with beneficiaries, helping people to enroll in coverage. And that's how I think we begin to balance the tension that you're describing. And at the kind of operational side, that means that we've got to have clinical teams that understand how behavioral health gets delivered, how dental care gets delivered, for example. We need to have teams that can really translate data to make it more human-centered, and that we can really understand how the healthcare system is shaping and changing, because it's having tremendous impact on front lines of care.
It's really exciting to hear you talk about that. And you know more than anyone that you could easily fill your calendar every single day with meetings from those who have the resources to have a presence in Washington. So It's great that you're getting out. Well, I'm going to shift gears. There are many directions we could go. Not surprisingly, based on the questions that have come in to me, a lot of people have the Inflation Reduction Act on their mind, as do I. I know we're not that far past the date of signing, and some of the timelines stretch out for quite a while. Maybe I'll start with a broad question, and then we can, again, like we did with these others, dig in a little bit more. But talk to me about how you're approaching implementation of the Act. And of course, the primary focus I think people will have is on drug negotiation, but there are many other provisions. So I'd be interested in your thoughts on any of those.
Well, I think about the changes in a couple different ways. First is the Part D drug redesign is going to have tremendous impact and to many, many Medicare beneficiaries. And so I had the privilege of working on Capitol Hill when the Part D benefit was debated and drafted, and the Part D drug benefit design was built not based upon good clinical design, but based upon the budget realities during that time period, and things like donut holes and how the catastrophic benefit worked and how the deductible was set with not a clinical discussion, but a budget function. So as the Part D benefit redesign phases in over the next several years, the Part D benefit will truly become a much more clinical benefit that will have tremendous protection, starting with insulin, but the catastrophic benefits will be so impactful to those who have the most serious need, cancer, for example. And so to me, just a tremendous change to our programs to better serve beneficiaries. More people will qualify for low income assistance, which to me is one of the fastest ways to get economic relief to those covered by the Medicare program. The law next 3 years will extend the subsidies for those covered by the marketplaces, and so that will give us an opportunity to continue to expand coverage during the next several years. And so that's going to be tremendous change for those that we can add to the coverage rolls. Then the next piece is drug negotiation, which will be a huge effort by CMS. The law is clear for how we are relatively clear for how we define which drugs are eligible for negotiation, at least in the first couple of years, and clear in what happens if CMS manufacturers don't reach agreement. But how we come to that process will be work that CMS has begun and become much more defined over time. How we're thinking about the implementation work will follow the six strategic pillars. We are going to make every decision with a clear lens for equity. We're going to engage all stakeholders to ensure that we're capturing the information. And I think one of our first earliest challenges will be to explain to beneficiaries the benefits, particularly the Part D redesign that's going to have benefits starting January 1st, phasing in over the next several years. But the opportunities for better care, better clinical integration of pharmacy benefits with medical benefits are huge. And we have this truly exciting new program to build for how we negotiate drugs. And that will be work that will rely on the readers, researchers, and those in industry that have that expertise. But that's going to be work that begins to shape during the next several months.
So I know negotiation is a fraught term, but you obviously have some very sophisticated and well-resourced enterprises on the other side of the table, if you will. What kind of skill set do you need at CMS to enter into those processes effectively? Do you feel like you have that? And by that, I certainly don't mean to like ask about the details of your staff, but are there skill sets and experiences that you feel would be particularly useful as you take on what's really a historically brand new role?
One of the areas are one of the skill sets that we have brought into the agency that I think is probably more common in private sector world are those that think about kind of system design. And so those that think about how you really create not just a policy framework, but how you create the interactions of the agency, for example, and with pharmaceutical manufacturers that will go into agreement for this negotiation. So one of the things that we've really done in the last couple of weeks, again, to kind of map this out and during the next several years, is to really take stock of how should the system work? How should we engage manufacturers that are in the first negotiation gear, if you will? What's the data that CMS will want to collect? What's the data that we expect manufacturers to submit back? And so, yes, we'll need people that know the ins and outs for how managed care plans contract with pharmaceutical manufacturers and the levers of negotiation that are commonly used on a PBM, for example, built a formulary. But I think we need first that lens of how do we create the system? How do you design the system so it's scalable? The goal of the law is for us to start with a relatively narrow set, but then to expand over time. How do we really create clear information requests to manufacturers so they can start planning for that, building that? And so we're not in a place of tension over the rules, we're over tension over what's the fair value. And so I think that skill set of system design, how will people interact with the system? That's a skill set that we've been building that will be necessary for how we build the next steps. Then we'll also need people that know the industry, know the process, know how to evaluate different clinical perspectives. We can come to the right negotiated price.
So I know that different actors in the sector don't all view things the same way. We talk about pharma as if it's a thing, but it's a lot of different perspectives and views. And I was struck over the last few years. There was a time when I heard a lot of discussion about paying for value and sort of value-based, applying value-based principles to pharmaceuticals. I think some of this came, I'll say it's somewhat cynically, in the wake of the hepatitis drugs, where the notion was, yes, they're expensive, but look at how much they're saving. And so it was sort of a way to say, you shouldn't be so concerned about how expensive they are. That I haven't heard as much of that language more recently. I also have certainly seen plenty of criticism of the sort of ICER cost effectiveness analysis approach. Again, no single method is going to capture everything, but there's been a lot of efforts to sort of poke holes in those kinds of approaches. I'm curious about your perspective. You've sat in different chairs. Obviously, it's going to be relevant in the chair you're in now, but what is your sense of sort of the value-based framework for thinking about drugs and maybe other parts of the health system?
It's a really great question. I think value is one of these terms that means so many different things to so many different people. And so I think it's generally hard to get two parts of that healthcare system, or three parts, or multiple parts, to come together to define what value means. And I think for some, value means better healthcare outcomes. And that's certainly something that CMS believes to be true. For some, it means lower total costs. And I think that definition has, to me at least, there has been a lack of true consensus for how we define that. And so I think, maybe to your question, kind of one of the benefits of the drug negotiation process will be a greater consensus from both payer and manufacturer, but also other stakeholders that will come to, hopefully, a common definition of value and how you price that. I think one of the challenges kind of operationally of value-based contracts, particularly in the pharmaceutical world, is that the manufacturers generally tend to be willing to offer value-based contracts for those drugs that are truly expensive, truly breakthrough, but have a very small population, which means it's tremendously complicated for how you attribute the cost and the savings. And if beneficiaries choose to leave a plan, then how do you attribute the costs and the savings back and forth? So those models tend to break down just to the operational realities of how healthcare works. But with the IRA, the drugs that will be chosen, by definition, the law standard would be those that are generally widely used, the most expensive drugs. And so there, I think we probably have a stronger foundation for us to attribute value and to assign that value back to the payer, the beneficiary, and hopefully the manufacturer. So, but thinking about the design process, if you do it well, maybe that we can come to some common frameworks, some common definitions for how we assign value, particularly with pharmaceuticals, biologics, and we can really build those models, not a drug that treats 4 or 12 or 20 people, but those that treat millions of people. We can really attribute the savings, the value, much more reliably.
Well, when you started to answer, I thought, boy, that's optimistic to think you can reach agreement across the different stakeholders on this. But you make a really important point, which is that where the process begins is with a collection. I'm not going to call it because they're very different individually, but with drugs at a certain point in the marketplace, I should say, where it does seem like the data availability, the large numbers, the conditions they treat are such that they're probably more amenable to some consensus around value than either the ones that are effective for a very small number of people or are pushing the boundaries of some of our biotechnologies where the expenses are exceedingly high per unit. So it would be nice if this could clear the way for some agreement there. That's great. I'm going to, yeah.
We're optimistic. Yes.
Good. You have to go into this being optimistic. So I'm going to bring up a totally different topic. When I started at the National Academy of State Health Policy, boy, that was 18 years ago, we were working on a project on dual eligibles, Medicare and Medicaid. Of course, before the ACA, we didn't have the office, coordinated care office that was designed to bridge these two programs. You mentioned in your opening the growing attention to Medicaid, given the numbers. Of course, you will recall the joke when CMS was named and it only had one M, it was sort of obvious which M it meant. But I think today there is more of an understanding of the relationship between the program, but still structurally, you used to run the Medicare side of it, there are structural divisions between, there are huge differences from a beneficiary perspective in how these programs run, benefit design, role of managed care, and the like. I promise I'll get to my question. We just had a paper looking at DSNPs, the dual eligible special needs plans, showing not really any different from MA plans in general. And that's probably just a reflection of where we are in the evolution of what the DSNP's role is. This is an issue that's been with us for so long. There's no one answer. But if there's anyone who has had the perspective to really think about what it would take to do better for these, the most expensive and the most frail in both programs, it seems like it would be you. I'd love to get your thoughts about where we go with this incredibly important population.
Yeah, it's such a great question. And there's so many different ways to respond. For me personally, both being at CMS when some of the models were launched, that following the Affordable Care Act, seeing their evolution during my private sector time, but then also working with the team here, there's a couple learnings that stick out to me at least. One is we payers, states, CMS, providers, we have not figured out what true care coordination means, how we really engage patients in their care. And I think every model that we've looked at, particularly in the dual eligible models, we really engage patients. You tend to spend more because one reality is that those who are dually eligible probably don't have the greatest access to, or the best access to care, and if they're in a traditional kind of fee-for-service system. So we have to acknowledge better going forward that there is going to be resource need for the population. Second is we're still, despite all the years and despite all the time, really at the infancy of how we predict and really understand who needs care, who could benefit from care navigation, care coordination. I personally worry that payers get too reliant on data algorithms and claims analysis to predict. By the time the claims analysis catches up, that it's too late. And so I think we need to trust more providers, which of their patients could really benefit from more intervention rather than data kind of algorithms. A third is culture, particularly with kind of organizations that work to kind of integrate these models. It never fails that when you think about a health plan that's working to integrate dual eligible care, then it's never clear that a Medicare product, Medicaid product, and then the side of the Medicaid doesn't understand the Medicare side and vice versa. And so you never see a plan, or I should say, you rarely see a plan that's truly operating it from the perspective of, we're going to do this different. That was, I think, part of the impetus of the dual eligible office, the Affordable Care Act created for CMS to really think differently about how we're going to organize care for dual eligibles, rather to argue over it. Is it a Medicare policy or a Medicaid policy? No, it's something different. So I think we have more work to do. And going back to the theme of really listening to what beneficiaries want, there are some states that do a phenomenal job at really capturing that patient voice. I think we need to learn from those that do that, and those listening to providers for how to engage patients, listening to patients for what they need, really understanding how to do care coordination, culture coming together. So it's not a tension over Medicare versus Medicaid product or policy. That to me is the learnings going forward for how we do better to truly integrate. Tremendous progress to be sure, but to me, more learnings for us to focus on going forward.
Well, it's very consistent with the goals you set out at the outset. So I am very encouraged to hear that. I think I'll take one last topic before we close. We talked a little bit about value assessments for drugs, but of course, there's been a whole longstanding goal at CMS to move people into accountable systems, to elevate the use of value-based payment, or and again, it's gone through various names and iterations, but the whole sort of pay for performance, pay for value enterprise, we're far enough in it now that we've learned a lot. We've published, of course, at Health Fairs and other journals, a tremendous amount. If you could just step back and put it in the context of all these other challenges and work that you're doing, I'd be curious on your perspective. If someone were to say, how the effort to change payment to reward value, how's it going? What have we learned? Are we on the right track? What would you say?
Would say, in all honesty, that I'm not so sure. I think in during my first tour at CMS, we tracked very carefully the readmission rates, and we saw those come down, and felt that the course was right. We saw tremendous participation in more accountable care models and or other kind of payment models. If you look at the whole sort of collection of quality metrics, you see some positive signs forward, you see some signs that are neutral compared to non-accountable care, for example. So I think there needs to be more work to refine the models, define the models going forward, and really think about what's necessary going forward. And so the things that we think about, that I think about, of some of the value of what we should strive for with accountable care, value-based care, whatever we want to call it going forward, it really kind of, to me, stems from the pandemic experience, particularly for the CMS populations. And so those that suffered the most were those that had multiple chronic conditions. Those that suffered the most were those who were isolated, either in a nursing home or in their home. Those that suffered the most were those that had progressive chronic kidney disease, renal failure. And if we believe in value-based care and accountable care, that's precisely the population that should be the focus. Those who have progressive chronic conditions, multiple chronic conditions, those who have challenges with post-acute care, nursing home care, living in isolation, those who could benefit from targeted food support, transportation support, housing support, where appropriate. And so, to me, the silver lining to the pandemic gives us the opportunity to redefine what value-based care is, redefine what accountable care is, and begin to frame it as not as a business model for providers or kind of organizations that then leads to how you code better, how you submit your quality metrics better, but really a fundamental pivot to focusing on those that tend to be those who are most dependent on CMS programs, and helping to delay progression of chronic illness, helping to manage chronic kidney disease progression, helping to give supports to people who are isolated and living in a nursing home, for example. That to me is the opportunity for us to come back to. But I would probably personally share the perspective of Health Affairs. The jury is out, the data is mixed, but to me, we need to really define the purpose goals going forward, better define the purpose goals going forward, and really consider those that suffered the most during the pandemic and creating the opportunity to do better going forward.
Well, I will just say personally, I really appreciate that answer, and not only the uncertainty, which I think the humility is warranted, but also the notion of what are we really valuing when we say it's value based, and who are we valuing, and I'm really taken by your response there. I appreciate it very much. We just have a couple of minutes. I always like to end with a question about your own career. You've had an amazing run, and here you are back in this incredibly consequential and important role. It seems a bit of a hackneyed question, but I'm always impressed at the answers I get. So I am just going to ask, if you've got some younger, earlier career folks listening today, what would you say to them that you hope they'll keep in mind as they're thinking about their developing career?
Well, I think two things come to mind. For me, having both worked in government, the for-profit sector, but also the nonprofit sector, I think it's true for most people that have spanned kind of multiple sectors. There is no place that has a greater impact than public sector to spend your time in terms of reach, complexity, and just the ability to shape programs, shape people's lives going forward. The second is that I've been fortunate to be in government roles when something's been created, new law's been created, our law's been passed, but now you have to build a program. And so I often give the advice to people: find opportunities where you have the opportunity to build something, a new office coming online, a new program, either at the federal, state, local level. But the skill set that you'll learn, building a team, figuring out the operations, figuring out how to change behaviors for those that don't necessarily have to do what you say, that's an incredible skill set. And so when people are thinking about different opportunities in federal, state, local government, what I say often is the best opportunities might not be the ones that give you the most exposure to a decision maker or to a particular office, but the best opportunities are those where you have an opportunity to create, to build, and that's where you can have really great impact.
That's such a thoughtful answer. I really appreciate it. And I look back on my own career. I won't bore the audience with it, but I think I'd never thought of it that way, but those were the most amazing times. So thank you for sharing that. Jonathan, thank you for talking with me today, for your insights, for your service to the country, to the so many Americans who are dependent upon the wisdom and judgment and values that you bring to the job. I'm really grateful and to have you in the role that you're in, and appreciate you being my guest today.
And thank you to your readers and to your authors that help make CMS programs better every day. So thank you for that.
That's very nice to hear. I will just close for the audience. If you like the spotlight, visit healthfairs.org and sign up for other future events. We have launched a new membership program called Health Affairs Insider that offers exclusive access to content beyond the journal. You can gain access to exclusive events, a curated newsletter on priority topics by signing up on our website. And we do have always more events coming up. On October 3rd, we will release our October issue on disability and health. You see some events listed up on the screen, including a symposium on October 3rd, the day the issue is released at 1 p.m. and an in-person community event in Montgomery County, Maryland on October 6th. We hope you can join us for these and other events. Thank you all for your attention, and to those who submitted questions, I appreciate your engagement. We hope we'll see you again, and we are adjourned.